I'd like to welcome everyone to the very first episode of our podcast series for Radiology Imaging Cancer. Radiology Imaging Cancer is a journal sponsored by the RSNA, dedicated to research and clinical translation and clinical care of imaging applications in cancer and image-guided therapy. Our podcast series will air approximately once a month, and we will cover not only content in the journal, but we'll move beyond that to investigate and speak to the people behind the work in imaging cancer and some of the people who are working in our field to advance imaging in all aspects of cancer research and cancer care. So to introduce myself, I'm Gary Luker. I'm the editor of Radiology Imaging Cancer. I'm also a professor of radiology, biomedical engineering, and microbiology and immunology at the University of Michigan. And I'll be hosting this segment of the production along with Adeline Boettcher from RSNA, who will now introduce herself.
Hello, I'm Adeline Boettcher, and I am the scientific editor for Radiology Imaging Cancer, as well as Radiology Artificial Intelligence. So just to give a little bit of background about myself, last year I finished my graduate work from Iowa State University, and I worked with characterizing biomedical models in swine. I've always had an interest in cancer research, and some of my projects in swine revolved around the development of cancer models in pigs. After graduating, I did a short-term postdoctoral fellowship at Northwestern University, working on immunotherapies and mouse prostate cancer models. However, through all of this work, I found that my passion was with scientific writing and editing. So now here I am as scientific editor at RSNA. So my job is to read through manuscripts and ensure that there is clarity in the writing, as well as in the presentation of data in the results section, but also in tables and figures. So when I read through manuscripts, I think of ways to make it very easy for readers to understand the broad findings of the results in the papers. So I always look forward to reading about the new advances that are being made in cancer imaging research.
Addie also markedly understated her position with the journal. She is instrumental in generating content for the journal, including several commentaries that will be coming out in the journal very shortly. For this inaugural podcast, later on we'll have presentations from recipients from the RSNA Research and Education Foundation, so grant awardees, who'll be talking about our research. But for right now, Addie and I will be talking about an article that she and I wrote very recently and was published online for Radiology Imaging Cancer about transitioning to a new normal after COVID-19 and how we can prepare to get back on track for cancer imaging. So this piece was really designed to understand the changes, challenges, and impact of COVID-19 on cancer imaging at institutions throughout the country and even world, and on research in cancer imaging. So we asked leaders in cancer imaging from the United States, United Kingdom, and China to describe how their institutions handled the rapid shutdowns and scale downs of research and clinical care related to cancer and what impacts they anticipate moving forward. As we transition out of this pandemic, I'm sure that these responses will evolve over time, but we'll give you a snapshot of what people thought. One of the very first tasks that institutions had to manage was to determine what types of cancer imaging appointments could move forward and what ones had to be rescheduled or postponed for a later date. The objective really was to keep people safe and healthy, first and foremost, weighing the risks of delaying cancer imaging versus the risk of infection and disease from COVID-19, and also to preserve personal protective equipment, so the safety gear that people use in hospitals to protect themselves from infection. That became a very precious item in many hospitals, and any effort to preserve that for the actual COVID-19 patients was invaluable. In general, urgent appointments, which were defined as imaging appointments that were either follow-ups or high-risk cancer, or when imaging would change the course of therapy, were kept where originally scheduled. But elective screening appointments, or where imaging did not or was highly unlikely to change the treatment plan, continued as they were originally planned, but they were shifted back in time, so rescheduled.
So we assembled this piece back in the beginning of April, and since then a lot has changed with respect to institutional closures as well as stay-at-home orders. At that point in time, in the beginning of April, the stay-at-home orders were either being extended through the end of April or through May or even through June in some places. And now in many states, there's a lot of talk of reopening. And in that process, there are some imaging facilities that are beginning to reopen for appointments. States are continuing to monitor new COVID cases, but as stay-at-home orders are being loosened in some states, some imaging appointments can be resumed now through the summer. However, social distancing, layoffs, and a reduced number of patients with health insurance may result in either appointment delays or cancellations, depending on different places that patients may be. As mentioned earlier, one of the major consequences of the stay-at-home orders was that rescheduling of appointments during the approximate 2-month time period of shutdown could potentially cause a large surge in appointments once restrictions are lifted. A surge would be particularly challenging to handle as many institutions and imaging facilities already operate imaging equipment at near capacity. So, having all this information, it's very likely that it may take many months to compensate for this lost time. However, there may be certain imaging protocols that could be shortened to shorten appointment times. Additionally, institutions could extend hours into later in the evenings or even in the mornings or on weekends. However, in addition to this, there will also need to be new and aggressive cleaning measures will also be needed in between appointments. So, this will just have to be taken care of on an institution by institutional basis.
So following up on many of the points that Addie just talked about, we further asked the panel to describe and really project how the break in screening and cancer imaging may affect the future, not only in screening for cancer, but imaging appointments. And really, the panel brought up, I thought, some very important points that patient mentality about screening may not change. In other words, patients may see the value in continuing mammography or lung cancer screening, but their ability to actually access that part of healthcare may be dramatically changed. Health insurance in the United States, in particular, is highly tied to employment. And the United States is clearly experiencing record job losses. With that, many people may not have insurance and insurance coverage to actually come in for normal screening appointments. So these people may likely delay their screening until they have employment, likely missing important opportunities to intervene early in cancer. We also have the concern that in some cases, patients who are seemingly in remission with their cancer may not decide to reschedule their appointments for follow-up imaging just because they deem the risks of exposure to the virus to be greater than benefit from imaging. And lastly, we addressed a very important topic. What is this going to do to the future of research in cancer imaging? During the very beginning of the shutdown, research labs throughout the country and world were asked, typically on very short notice, to shut down their research operations. Sometimes places had up to a week or 2 weeks to do this, but at least for my institution, we had less than a week to completely shut down our research operations to critical and emergent activities. So during the process of ramping down, obviously, we and other laboratories had to basically halt any non-essential work, restrict animal research, and many times losing important reagents and pieces of data that we might have generated otherwise. Similar problems occurred for those doing clinical studies in cancer, so clinical imaging studies. With rare exceptions, those studies were postponed and had to be delayed until a future time. So we've lost a lot of opportunities for generating important data in cancer research as a result of the pandemic. Now that is balanced, of course, by the fact that people were largely working at home, and there were opportunities for students, faculty members to begin working on manuscripts and grant proposals. And I suspect that agencies receiving grant applications this fall will receive record numbers of applications. Many people also took the opportunity to begin retrospective studies in cancer and cancer imaging. Within the next few months, there was a lot of uncertainty about how to transition back. So how do we make up for the lost data in prospective clinical trials? Obviously, there will be lots of violations of IRB protocols because of this. The FDA will need to have some policies to account for that. And as we resume wet lab experiments at the bench, workplaces will need to enforce and be very creative in many ways, options and opportunities to maintain social distancing in the lab that enable research to be done while keeping people safe.
And there are also some concerns about what the long-term economic implications will be. So We are already starting to hear about how there could be economic shifts in the future due to the pandemic. And in our piece, we talked about how there may be a potential reprioritization of funding agencies to fund projects related to infectious diseases and pandemic responses, which could consequently reduce funding in other areas such as cancer imaging research and other areas. In addition, due to some institutions are funded, by appointments being made, there may be reductions in internal or other external funding opportunities. So there may be a shift in the types of research that we see being funded in the next years or months to come. So in all, the COVID-19 pandemic has caused disruption in a variety of sectors, including cancer imaging. And as imaging and research institutions begin to open back up again, we will see that there will be new practices that will need to be put in place to help ensure that patients, healthcare staff, and researchers can continue to be protected while also continuing their important work.
So thank you for joining us for this segment, and we encourage you to listen to the rest of our podcast and join us as we compile and present new editions in the months and years to come. Thanks.
The next segment of our podcast features Imaging Cancer Deputy Editor Luke Wilkins, and he will be interviewing a recipient of the 2019 RSNA Research Medical Student Grant.
Hello, this is Luke Wilkins from the University of Virginia. I am one of the deputy editors of Radiology, Imaging Cancer, and today I'm going to be talking with Monica Matsumoto and Sam Mouli from Northwestern University, and we're going to be talking about their recent grant, Chemoembolization Combined with Immune Checkpoint Blockade in an animal model of hepatocellular carcinoma. So thanks, guys, for joining me today.
Thank you for having us.
Thank you.
Awesome. So tell me about immune checkpoint blockade and how it kind of currently relates to treatment of HCC.
Sure. So liver-directed therapies such as Y90, TACE, and ablation have proven to be beneficial in the treatment of HCC. However, additional therapies are being investigated for patients who continue to progress or who aren't candidates for these therapies. Sorafenib and other kinase inhibitors have been used for years as systemic therapy for unresectable HCC, but outcomes unfortunately remain poor with expected survival less than 1 year. Now there's a lot of excitement about immunotherapy, but results of initial studies so far have had modest, at best, survival benefits. So first, the main idea behind immunotherapy is in the pathophysiology of HCC itself. So HCC develops from inflammatory and immune-mediated processes, such as from viral or alcoholic related hepatitis. And then second, we know that immune checkpoints regulate immune activation, and they're critical to maintain a balanced normal immune function. But in cancer, immune checkpoint markers can allow cancer cells to go undetected by our immune system. So, for example, high levels of immune checkpoint markers such as PD-1, PD-L1, and CTLA-4 have been associated with immune exhaustion in HCC, and that's associated with a poor prognosis. So it's theorized if we block these markers, we can restore immune function and induce an immune-mediated tumor rejection. So essentially, we're hoping the body does the work of destroying the tumor cells for us. In HCC, the first immune checkpoint inhibitor was nivolumab, and that was approved in 2017. There are other immune checkpoint inhibitors approved for other cancers like melanoma and small cell lung cancer. Now there are a lot of trials for HCC in an effort to find a drug or combination of drugs that improve survival without being too toxic. So these combination therapies are becoming increasingly popular. However, these studies are lacking preclinical models to guide efficacy, and this is where our project comes in.
And so has there been previous research on immune checkpoint blockade and local regional treatment of HCC? And has it always involved embolization treatment, or have there been other local regional therapies that have been used in combination with ICB?
Yes, so there are several different trials, even ongoing now, looking at TACE combined with immune checkpoint blockade, even Y90 now, and then some ablation therapies.
There was a paper in 2017 that was published in Hepatology looking at chemoembolization and ablation and immune checkpoint blockade of CTLA-4. However, it's really unclear what the timing was in terms of the blockade and the different liver-directed therapies. And while there was somewhat of a response, we haven't been able to reproduce anything like that since then. And we have a lot of unanswered questions in terms of dose, timing, toxicities, things like that we really want to work out in an animal model to make it easier than doing it in a large clinical trial.
That's fantastic. So how does your research fit into those glaring gaps in knowledge within ICB and within local regional therapy?
Yeah, Sam said one of the main things we don't know is, well, first the dosing, but also the timeline of immune response to these therapies. So, do we do the liver-directed therapy first and then follow up with immune checkpoint blockade? If so, do we deliver the immune checkpoint blockade after 1 week or after 2 weeks, 4 weeks after the liver-directed therapy, or is it longer or shorter? So again, this would be really hard to do in patient trials because follow-up with imaging, biopsies, labs would be really intense for patients to go through. And so we're trying to determine that in the animal model, essentially measuring immune response after TACE at 1 week, 2 week, 4 week marks.
Okay. Tell me about your animal model and kind of your research design for determining this timeline.
Yeah, there are a couple of things that went into trying to come up with the most ideal animal model. We are using a chemical-induced form of HCC, or liver tumors, in rats. And this was chosen because it more closely mimics the human pathophysiology of HCC development, which is the inflammation fibrosis pathway. This is better than some of the xenograft models or the genetically modified models, which make it difficult to evaluate the tumor microenvironment. So we're giving diethylnitrosamine, which has been used in other rat models before, and we're essentially putting it in their drinking water and then evaluating them after several weeks to see if they've developed tumors.
And is there any difference between animal model HCCs and their immune markers versus human HCCs? Or did you have to factor that into consideration when considering your animal model?
Yeah, there is many differences. Obviously, the antibodies and everything, the targets are somewhat different between humans and animal models, certainly. I think the big picture that we're trying to look for is not necessarily coming up with the one-to-one correlation between liver-directed therapy and these immune-mediated processes, but trying to find a window in which this occurs so that in future clinical trials, we can say, we should really be looking, for example, at chemoembolization at the 2 week mark. And so then we can design a study such that patients are receiving their immune checkpoint blockade analysis and labs and biopsies and such at the 2 week mark. So at least we have a window. As it currently stands, the clinical trials that are being designed, they're either putting them very close together arbitrarily, the checkpoint blockade and the liver-directed therapy, or spreading them out really, really far, like months difference, so that there isn't any overlap between adverse events and side effects and such. So we're trying to at least find a window with these different liver-directed therapies in which to do further investigation in a clinical study.
And tell me about some of the challenges with working with a rat animal model and doing embolization from a technical standpoint. Because certainly rats are somewhat smaller than people, and doing an embolization on a rat must be technically challenging.
Sure. It is. Well, one thing I've learned, it's extremely challenging in general, translational research, but it's also really, exciting. But the lab, fortunately, had already developed a technique for doing transcatheter embolization, hepatic artery embolization, using laparotomy approach. So, that it does require a lot of fine motor skills and a lot of practice to refine. But I think we've gotten really far and are pretty successful. And then as far as developing the assays, that is a second challenge, but something that we also made a lot of progress with. So we had to create our own multicolor flow cytometry panels and work with the core facilities at Northwestern to develop our own histopathology stains. So a lot of stuff had to be specialized to our rat model because most studies are in mice, but again, mice are too small. We can't do it in mice. So a lot of stuff we have to coordinate. That's part of the research process.
So originally when you were designing this research, you were going to be focusing on Y90, but then you switched to chemoembolization. So what led to that switch in that research plan?
So what we've learned, and Monica can attest to this also, is that a lot of this was, we had animal models in place that we had used previously for HCC. We had animal models in place that we had done for liver-directed therapy, but combining those, coming up with the assays, all those challenges, logistically, we wanted to make sure everything was set before we started using Y90, just from a radiation safety standpoint, also cost, So now that we've really worked out a lot of the kinks, I think we can safely perform Y90. We just wanted to make sure that, because of the cost and everything associated and, people handling specimens and stuff, we wanted to make sure that everything was set before we went to that next level of analysis. Now we've gotten more comfortable and we've started doing some Y90 studies in general, and we have histopaths set up such that they can handle the samples without contaminating anything. We have immunoassays set up so that they can handle that without contaminating anything, things like that, animal holding. So a lot of logistical things that we had thought of initially, but got more complicated as we got deeper into the study. So we just kind of pushed that back until it was, safe to do.
The joys of translational cancer
Exactly.
research. And so what did you learn about the immune response of HCC post-TACE and the timing of that immune response?
Great question. We are still working on increasing the sample size and finalizing the assays. So we don't have final results yet. We started with the control rats to sort of set up the assays and create a baseline. But in our preliminary results, we have seen some signs of a spike in immune response at 1 week for the bland beads. And then both at the 1 and the 2 week mark after treatment with the doxorubicin loaded beads. So this suggests that there may be a difference between the two, but again, we are still in the preliminary phase.
Fantastic. And I know it's a little early, but what do you see as some of the future directions of this research and where you hope to take this next?
Basically, as Monica mentioned, we've done the initial immuno work. We're looking at pathology, PDL1, CTLA4 staining on path specimens, which we're reviewing with a veterinary pathologist. Now we've kind of created the framework for how to do not only the technical aspect, but also the assessments of the immune response and the imaging and the pathology. And we want to broaden this to not just chemoembolization, but also Y90, as I mentioned, and even ablation. So basically, our goal is to come up with this chart, so to speak, that says, okay, this is when you should add immune checkpoint blockade with ablation. This is when you should add it with bland embolization. This is when you should add it with chemo, with Y90. And then we can take that preclinical data and then hopefully translate it to a clinical study in which we know the time points that we should be looking at in patients for when we should be doing the immune assays and when we should consider adding immune checkpoint blockade.
Fantastic. And I did have one additional question about your technique and about kind of immune checkpoint blockade. Previously, it had been kind of discussed that these tumors should be partially treated so that you don't destroy all of the immune response so that the body can still mount that immune response. So what technique would you see people adhering to ensure that there is only a partial treatment of the tumor to allow for that immune response? Or do you believe that the treatment itself is palliative in nature, so therefore there will always be some degree of tumor tissue that will allow immune response?
It's a good question. I think a lot of this will be probably, if when applied clinically, it will be in the cases of patients with, multifocal or bilobar disease, so that you're only treating one side. Because as it currently stands, you can't really chemoembolize the whole liver on a single setting, or Y90 the whole liver, or even ablation for that matter. So in these patients that have diffuse unresectable disease, if we treat part of it, kind of prime the immune response, and then see the rest of the tumor burden change, that would be the ideal situation in which we envision doing this.
Another interesting thing is going to be if we can compare the TACE versus the Y90 results, even from our study, or if we're able to do this in humans, because I know they have different mechanisms of action too, and the induction of hypoxia. So that would just be another interesting way to look at it.
Absolutely. So I guess this last question is for Monica. How has the RSNA-RNE grant kind of impacted your career plans, and where do you see kind of taking this experience forward? Sam, I already know your career plans, so that's fine.
I mean, one of the best things about the grant was really allowing me to continue doing the research that I started back in 2018 at Northwestern. So I actually did a research year between my third and fourth years. And I'm at medical school at University of Chicago, but Northwestern was gracious enough to let me come and work with them. And then so being able to continue this research during my fourth year was really great to have a more longitudinal experience. And then secondly, getting plugged into the RSNA community through the grant, going to RSNA last year and getting to hear what type of research everyone else is doing. And I'll sort of rewind too, as far as like when I came on to the lab, Sam was just starting up the projects and having the ability to start these from scratch, and now handing them off to the next research fellows and seeing that, we have several projects out there running now, and that's just really exciting. And the infrastructure and support at Northwestern was really incredible, from Sam, from Riyadh Salem, and from Andy Larson especially. They were hugely supportive. And then for me personally, I am excited to have matched in interventional radiology at University of Pennsylvania. So, of course, I'll be trying to learn everything I can over the next 6 years about IR, but I also really love doing research. So I definitely plan on being involved as a resident. And fortunately, Penn has a really great infrastructure as well. They have their Piggy lab. I don't know whether or not I want to pursue like clinical research, translational, or something else as a resident. So it's still on the table, but looking forward to that for sure. And definitely to a future career in academics.
Well, congratulations. We are very much looking forward to seeing the final results of your research with Dr. Mouli and looking forward to seeing how your career unfolds. So thank you very much for taking the time to talk with us here and looking forward to everything.
Thank you for having us.
Thank you.
We hope you enjoyed this podcast. We will be bringing you new podcasts on the first Friday of every month with updates in the field of cancer imaging research. Please review, rate, and subscribe to this podcast to stay up to date on new content.